Okay, this is a four-chamber view acquisition in which the apex is around 12 o'clock. And what I want to point out is, while this is the orientation used for taps and maps with an M mode, or with tissue Doppler analysis for looking at the base of the heart, it's not ideal necessarily for our fetal HQ. And the reason for that is, while you can see the lateral wall of the right ventricle here nicely, the septal wall drops out. This white echo is not the full thickness of the septum. It's actually a muscle band that's in the center of the septum. Because of lateral resolution, you're not picking up the full width of the septal wall. Also, we get some drop out of the left ventricular wall. So this is not ideal for our imaging acquisition for fetal HQ. In this orientation, we have the apex at about a 15 to 20 degree angle from the center of the screen. And now we're picking up more of the endocardium of the interventricular septum, as we see here. And here we have a nice image of the myocardium of the left ventricular wall and the right ventricular wall. So this is a better orientation. And so if you have the apex up at 12 o'clock, by simply moving the transducer across the maternal abdomen, you can reorient it and angle it this way to pick up the septal wall much more clearly. This is another example of reorienting the four-chamber view, and this is probably ideal because you're at about a 45-degree angle to the ultrasound beam. You're actually combining lateral and axial resolution. You see very nicely the interventricular septal wall. Here's that bright echo that I mentioned earlier, and here is the septal wall of the left ventricle. So we have nice valve movement and a nice delineation of the walls of the heart. And this is probably the very best orientation for acquiring an image for fetal HQ analysis. Once we've identified the four-chamber view we want to analyze, we're going to start first by drawing a line perpendicular to the annulus of the left or right ventricular chamber. This is annular movement on the bottom. We're going to move our cursor to in diastole. Here is systole, here is diastole. So we're going to select this point right here and this point right there. And we're going to adjust this so we have it peak right there. Okay, that's the first step. Next we go to now selecting the chamber. We're going to go to the left ventricle first. You see a nice graphic, 1, 2, 3. This is a sequence which we're going to take and touch the walls and the septum with our red dots. And this will now give us a nice contour of the left ventricular chamber in systole. We click next. And this is the end diastolic trace, which tracks it very nicely, and we hit accept. And this is our left ventricular contour. We're now going to go to the right ventricle. And again, it asks us to touch the red dots at septal wall, lateral wall, apex. We'll do that right now. Here's the septal wall, here's the lateral wall, and this is the apex. And we're going to do a little adjustment. And bring these dots into the septum. Okay, that's systole. Now we click next. And here is diastole. We only have one little adjustment. This is very nice. Let's adjust this just a tiny bit. But you notice how clean, with a good image, how clean this algorithm tracks the endocardium, and with very few adjustments, you have the correct endocardial mapping. Here we have the left ventricle and the right ventricle. In the normal fetus, about 20% of the time, you'll see along the base of the septum a little movement, and then it, of course, moves towards the center of the chamber in the mid and apical regions. On the septum on the right, often we see no movement of the septum at all. Sometimes it goes to the left, but very few times does it go to the right. So this is a typical septal contour that we see on the right. Now we're going to take a look at the report. And we have the end diastolic diameters, fractional shortening, and the sphericity index.